Okay, thanks for joining us, Kiran. So we were just doing a 2-minute run through in this group with what is NHA, what is ABDM, going through the UHI.
Anyway, I'm going to cover that as part of my little talk anyway. So
awesome. We just did like a 1-minute guessing. So no, but great to have you, Kiran. Just to give you a perspective, everybody, like I was sharing, we have Kiran Anandapillai with us. He's the CEO of iDrishti, and iDrishti is a social impact eye care chain delivering affordable eye care in unserved markets. He has been the key driver behind the key designer behind the entire ABDM, NHA's UHI initiative, overall ABDM, and focused a lot on integrating more bodies for UHI, essentially what we were talking about right now. He's actually been the person who's been there. I think, Kim, you've been one person who's been there with NHA from the early days when ABDM was conceptualized to today. And I think everybody who's there at NHA, looks up to you for the design guidance, and also now Kiran is building a community around the NHA ABDM product. So which is why the projects that you see today also from ABDM is thanks to Kiran being able to get a community together and then sort of get these problem statements out, and in the future even have more problem statements coming up. So Kiran, great to have you here with us. Just to give you a perspective, we've got all the selected contributors. As you would have seen, we had about 900 people who participated in and submitted proposals. Out of that, we have 103 who were selected for this mentoring program, and they are all here. This is that bootcamp that started yesterday, will continue to Thursday, followed by the inauguration event on Friday. And then next week onwards, the coding will start. So we've been covering multiple things during the bootcamp, from what are some coding best practices, to how to do project planning, how to plan your own time. And the idea was to also provide some external perspectives every day on some important things that are happening and that everybody can learn from. So looking forward to your session, Kiran, and I think everybody's really excited to hear what you have to say, and then we'll do a question answer, as we move along.
Sure. Thanks so much, Supreet, for that intro, and hello everyone. Firstly, very big congratulations to all of you on being selected. I am certain that it was you guys may not have known how competitive it was, but I kind of know, because I got 16 proposals and I was asked to pick one. And when I shortlisted, I had 4 really good proposals, and it was really for me, it was disheartening that I was actually losing potentially 3 great candidates who could have contributed out here. So the one person I had to finally pick. So I'm sure, and I heard from Supreet, that it has been like that for almost all of you. So all of you have really worked hard on your proposals, and the mentors have to pick you across many of the proposals. So firstly, congratulations. It's great to see the kind of effort and contribution each of you have put to get here. Now that we are here, I think it's really important that in the next 2 months, we figure out how we can get the best out of you. And I am here to kind of give you a high level picture of one of the digital public goods, specifically in healthcare. And so we'll use a small set of slides. I have only about 5 slides, so don't worry, there's not going to be too many slides that will play out. So I hope everybody can see this window and slides. Let me put it in slideshow mode. Yeah, yes. Thank you. So what we're going to talk about is a little bit of what's called the Ayushman Bharat Digital Mission. I'm happy to make this quite an interactive session. So if any of you have any questions, please please raise your hands on the on the Zoom piece, and then we can take a break to quickly answer your questions. Now, let's just quickly understand what's the problem these digital public goods are trying to solve. And to understand that, I think it's good to step back and take a look at how India delivers healthcare today and what happens in digital healthcare in India. So many of you might know India is actually a very, very large market for healthcare providers. There are more than 200 different layers across hospitals, diagnostic centers, clinics. Even the government's public health programs are now teleconsultations that are actually being used to deliver healthcare. Now, if you think about digital, digital can happen only if that hospital or that diagnostic center agrees to use a piece of software. And in fact, that's one of our biggest challenges in India. I don't know what percentage of doctors, and I have a quick query, and you can maybe answer that on chat or something. How many people think, what percentage of doctors in India do you think use a digital to record healthcare transactions or health information? What is that view? We have more than 1 million plus doctors in India who practice every day. What do people think the answer is? Let's see who's got close. 15 to 20%, 5%, 5%. So all of you are quite right. That number is far below 15%. Nobody knows what the exact number is. There have been a few surveys, but indeed, digitization itself is actually quite poor in India, especially from the doctor side. But there is something else in India which is actually health information, which is significantly digital. Can anybody tell me what that is? Use chat again. What is already digital in India when it comes to health and health information? UPI is actually for financial transactions, so it has no health data. Vaccine, yeah, I mean, that's for one vaccine, guys. COVID, which is where we invented COVID, but it's not necessarily true for other vaccinations. Ayushman Bharat card is not really health information. How many of you have seen a handwritten lab report? When is the last time anybody saw a handwritten lab report, right? So lab and lab information, almost even in the smallest of towns, if you go and get a test done in a lab, what you get a printed report. So if you're getting a printed report, it was something that was built or done with some software and some amount of digitization. So lab information is significantly digital. And the reason it is significantly digital is because it doesn't involve a doctor. It can be done by a lab technician. And then so you can force these things, and many of these things are automated. So there are software systems. So on my chart, you will see a diagram or a thing that says LIMS. That stands for Lab Information Management System. So there are a whole category of software that can connect to these machines that you use to do lab tests, pull the information out automated, and help you create and give you a printed report, even push it out to you on WhatsApp. So that is where a lot of digital data does exist. I'm sure you can understand it's also similar for CT scans, MRIs in the radiology side. So diagnostics is a big area where there is already digital. All the others, when it comes to it, which is usually called things like OPD notes, prescriptions, and even discharge summaries, they have a far less layer of digitization. Now, one part is, what is digital? And the second part, and as you guys know today, when you go and get a lab report, you might keep it for some time. If I ask you after 6 months after you have had a lab test, please tell me what was there in that. I'm sure almost none of you can find or fish that report unless you are a really super organized person. And one of the key things that we are trying to do here is in this mission is to try to see how we can get this digital health information to become part of what we call as every individual's longitudinal health record. So your health information over time, right? Actually, it's also very interesting when you start thinking about health information. Generally, all of you are very young. So for young people, you have a lot of health information from the age of 0 to 5. Everything from your vaccination records to any of the illnesses you face because of your developing immunity. Beyond 5, typically till almost the age of 45 to 50, your health record may be largely blank with sporadic some incidences that might happen. And then later on in life, again, you will have a lot of health records. So that's generally how most people's health information over time will look. But coming back to this question, most of us will actually take our healthcare, receive our healthcare in India from a mix of public and private facilities. So almost all of you got COVID vaccination that was free from the government. And many of you will be seeking private healthcare over time, and there is being health records being done. And so if you look at the little chart on the right, you can see that private healthcare dominates in India, almost 72 to 79%, depending on whether it's inpatient or outpatient of patients are actually seeking care in private healthcare. Now, if we really want to get these things that I spoke about done, question is, how do you do it? How do you get everyone in India, like all of you are today enjoying the benefits of UPI, right? But anybody knows, again, back to your chat, what is the year that UPI's specifications, the idea of UPI was first put out? What year do you think UPI started? 2007. Oh my God, somebody's really going back in time. So no, it's not that old. So thankfully, you don't have to wait a decade. 2015, perfect. Pratik, good answer. I don't know if you Googled it, but that's absolutely right. 2015 was when the actual specs actually happened. So just for you to understand this journey of an ecosystem, right? Specs in 2015, first implementations in 2016. And I can promise you all the first implementations were done by banks and almost nobody succeeded. Nobody got the user experience right. Nobody got the simplicity right. So it took almost till 2018 before UPI's uptick really started. And following demonetization and the change in a regulation, which is making UPI free pretty much for all kinds of transactions, is really when UPI took off to the point where it's one of the world's largest systems when it comes to transactions today. So health is on a very, very similar journey in terms of digital public goods. And this journey is being led by an entity in India that's called the National Health Authority. Now, all of you hear this term C for GT or the word DPI or DPG. What is the P in it? Public goods, right? So it's technology can always be created and it could be run by, like, for example, let's take search as a technology. The dominant player in the world today is Google, who's a private entity, right? Similarly, if Twitter thinks of it as a public town hall, and it's also a large participation that's held by a private entity. And therefore, you will see lots of conflicts where the government is constantly writing sometimes to Twitter to say, take something down, blah, blah. So similarly, the idea of digital public goods is really that in many spaces and in many areas, many times government should have a say and should potentially build digital public infrastructure or digital infrastructure that can make a difference to that particular sector or domain. So the Ayushman Bharat Digital Mission, which is led by the National Health Authority, is essentially the entity in India that has been tasked with creating digital public goods for healthcare. And it has its own budget. It has a budget and its own team that enables it to kind of do this. Very similarly, the government has taken a new initiative, for example, in commerce through something called, anybody knows? What is the equivalent for commerce? Exactly. So Shashwat got it. It's ONDC, which is the new initiative for commerce. Now, the next question that I'm going to ask is, okay, we are saying we want to create digital public goods in healthcare. What is it? What can we think of as digital public goods in healthcare? What are the big ideas? What is it that we should really build? So that's a big question, right? So now here all of you are quite young, but really you have to put on your architecture hats and start saying, what should the government do? What should the private ecosystem do? And if we can't design that right, and if you don't get that right, you cannot actually make it happen. So in UPI, and I think everybody understands UPI, again, there are so many players and parties with very clear roles of how we think their role will come in the ecosystem. So this is the same thinking we have gone through. So the thinking on what are the digital public goods for healthcare actually started, and I was part of that team that started thinking about it back in 2018. It's just a thought process, whiteboard, bunch of people gathering around in a room, throwing shots and saying, why not this, why not that? That's how technology, the best technology is always built. And that's what happened. So I'll show you what we ultimately came up with. So these are the three big digital public goods we identified that if a government can set up in a country, it can make a huge difference to that country in how healthcare is delivered over time. So the very first one is in the space of what we call as interoperable health data. So we talked about this lab test report, right? And we talked about the idea of longitudinal health records for everyone. So the first idea, which is very simple for, I think, most of you to kind of get, is we want every citizen to be able to get access to their own personal health records. So the idea is quite simple. You go to a hospital or a clinic, you should be able to collect your digital health records, and it should keep adding to your personal health records. And B, you should be able to share those with whoever asks for it with your consent. And this idea of consent is a super important thing in India, because this aligns with what is called as India's data protection bill. How many of you have heard of the data protection bill? I hope most of you have heard of something called the data protection bill. And the data protection bill is expected to be tabled in the parliament shortly, hopefully this year, and maybe as soon in the monsoon session itself. But that's a very key construct that the Ayushman Bharat Digital Mission aligns with. Now, I want to just tell you guys a very interesting story. All of us have recently come out of the pandemic, right? And the COVID pandemic. Now, can you imagine managing COVID if the government or the entities in charge could not tell where there is an infection and how many people are getting infected? It's not possible, right? You need to know who's got infected and where they are. And this is possible only if you have information from the test result, from the COVID test result. So how did the government get access to what is happening as the result of a COVID test? Across India, there were COVID tests happening, right? All of you got a RT-PCR done, or all of you got some tests done. So how does the government know where a COVID test happened and whether it was positive or not? And you guys would have seen newspapers who said so many tests got done, so many positive in this place. How did they do that?
CoWIN app, sir.
CoWIN was only for vaccination. It did not track tests. CoWIN does not track any COVID tests.
Arogya Setu?
Say that again. Arogya Setu, no. Arogya Setu was contact tracing app. Very different. So we'll park Arogya Setu? No, not Arogya Setu. So here is the problem. Do you think labs report their tests to the government? What do you guys think? Yes or no?
No, sir.
No, right? So how do they do it? So that is the challenge. It's a real big challenge. So what the government did was they passed a specific law or a rule under the National Disaster Management Act, not under Healthcare Act. So they said this is a national disaster, and in the case of a national disaster, in this case an epidemic, for the particular epidemic test, everybody has to mandatorily report their data in a new software that the government set up. So the lab had now got to do two things. If every time he did an RT-PCR test, he had to give you the test report, and he had to also go and enter the data in some government portal. So double work for everybody. Now, just 1 second. So that is the key way by which they actually got health information out. Now, one of the things that we are trying to solve for in ABDM is that we would like automatically the software system in the hospital to be modified, or in the lab to be modified, so that certain amount of data which is important for public health management is automatically reported. Classic example, a new TB case. There is a whole concept in India called notifiable diseases, where if a certain disease appears, it has to be notified so that, certain public health measures can be taken up. So the second thing that the HIECM, or the digital public good we're talking about, will do is to actually create a stream of data for notifiable diseases and for public health management. The third thing that's going to happen is creating large anonymous sets. So many of you, I'm sure, are quite interested in artificial intelligence and everything that's happening there. And as all of you know, AI requires a huge amount of data, and creating data sets is quite important. In fact, what is happening worldwide, that in radiology specifically, especially with things like MRIs, CT scans, and X-rays, AI is able to now tell better or as good as most radiologists in being able to spot for different conditions on your X-ray. So very quickly, a whole range of tools are now becoming available for radiologists to help them actually do better on their X-rays. So Supreet's question is, would data from the HIECM be also available as a digital public good for consumption by the public? It's a very good question, Sukhdeep. So the recommendation that we have given is that data from the HIECM which is coming out for public health management should actually be published as an open data set under a different policy, which is called the National Open Data Policy. It's called NDSAP. So there is a separate set of what you would say, not rules, but guidelines that the government has put up about government data being available across sectors. It's not specific to health, across sectors for more transparency. And so we have said that under that same rules, we should probably be publishing these data sets. Now, the second big digital public good that we've been doing is what's called as, in fact, there was a article that came out just today also on this topic, and I'll see if I can share that. Where did that go? On the second public good, which is called Health Claims Exchange. Hang on. So on your chats, I'm just putting a little news article that came out, I think today or yesterday. So this is an announcement by the IRDA chairman, which basically talks about how the National Health Claims Exchange is starting to go live between payers and providers. Now, here's another interesting problem that only India faces, right? Which is about how many of you have gone and got a health insurance claim done, right? I want to ask you a question. How many of you, what do you think is the cost of getting your claim processed? Can anybody give me a sense? So let's say you went to a hospital, there is a, what shall I say? There is a bill that comes for your inpatient stay, and post that inpatient stay, there is a claim that happens between your insurer and your hospital, right? What do you think is the cost of that claim being processed by the insurer? Any ideas? What range are we talking about? Are we talking about in a few rupees, hundreds of rupees, thousands of rupees? What do you think it is? Hundreds. How many hundreds? Give me some sense. Thousands. Okay. Hundreds. I think thousands. Good. All right. So it's an interesting question. So I'm going to twist this now a little. Now, in most countries, in India is strange because India is one of the few countries where we do insurance claims only for inpatient. Do you think that's the same way it works in other countries? And do you think outpatient should be covered? So let's say I just go to a doctor and then I buy medicines. Do you think that should also be covered by an insurance claim? Absolutely. So if you actually look at India's direction, which is called UHC, Universal Health Coverage, that should ideally cover both inpatient and outpatient claims, right? Now, in an outpatient scenario, what do you think is the total value of the claim going to be? One doctor consultation plus some medicines. How much do you think that average value of that will be? That means if I am a clinic and I am making a claim saying I treated Sukhpreet and I've prescribed these medicines to him, give me back my money. That's likely to be less than 1,000. Right? So if the cost of processing a claim is going to be thousands, do you think it is even possible practically to economically make this work? No, right? So this is one of the key problems that we are trying to solve with this new digital public good that's called the Health Claims Exchange. So how do you think that can be solved? The only way it can be solved is if you introduce a new technology that is called auto adjudication. What is auto adjudication? Auto adjudication is a machine looking at a claim and making a decision whether this should be approved or not, if there is a fraud in it or not. If you go to Western markets where these happens today, over 90% of the claims are automatically adjudicated. Less than 10% of the claims are manually adjudicated. What do you think the percentage is currently for India? Anybody knows? What percentage of claims in India, health insurance claims in India, are manually adjudicated? Yeah, it's near 100%. It's 99.9 kind of percent. We have very little to no auto adjudication technology simply because the claim process itself is not significantly digitized in India. And that is the journey that we are trying to take with the whole HCX as a digital public good. The last piece of this digital public good journey is interoperable health services. Now, let's take a look at teleconsultations. And I want to ask a question. What scenario is better for a doctor for teleconsultations? Your very first consultation with the doctor or your repeat or review consultation with the doctor? Correct. So repeat or reviews are much better because the doctor also has a context, you have a context, and in which you can do it, right? Review consultations are much better for teleconsultations. Now, the problem is that for you to do a teleconsultation in India today, does the doctor and the patient have to use the software from the same provider? So if I am using Practo or I am using MFine or I am using MediBuddy and I want to do a teleconsultation with the doctor, what software should the doctor have? Or same question in reverse. Do both parties need to use the same? Is that so? That is actually the problem. So this is the same in how UPI started. Only if the merchant and the consumer had Paytm could you do a transaction. But today, do you care whether the merchant uses Paytm or PhonePe or whatever? You don't know what the merchant is using. And in UPI, it's completely interoperable between the consumer and the merchant. Very similarly, UHI brings similar interoperability between doctors and patients. So you will be able to use any UHI app, just put the doctor's ID or the doctor, we call it a, just like you have an UPI ID, there's a doctor ID or a HPR ID, a health professional ID. You can find the doctor. You can then actually book an appointment, make a payment, exchange health records, and also get all of your prescriptions and everything back through an interoperable protocol, which we are calling as UHI. Similarly, the doctor can now use any software they want. So there is no tie between the two, but more importantly, the doctor can control their availability, how much they want to charge, and everything else, in the process. So in terms of the question that Shlok is asking, yes, absolutely, Shlok. The whole space is called fraud, waste, and abuse. So if you're interested in that space, look up FWA in the insurance industry. It uses a lot of different techniques, including machine learning techniques to identify fraud, but it also has a bunch of rule-based techniques. I'll give a classic example of one simple thing that happened. We saw a same doctor doing surgeries on the same day in two districts which were 200 kilometers apart. Not 200, I think 600 kilometers apart in a span, with the time of the surgeries being within 2 hours. It's not physically, practically possible. So simple rule-based stuff also can catch a lot of things in these kind of techniques, but there are a whole bunch of techniques to identify fraud, waste, or abuse. So it's not just fraud in healthcare. Waste and abuse is as big. So abuse is an example, means that I am providing a treatment to somebody who does not require that treatment. That's an example of abuse. Fraud is intentionally intending to make a claim when I have not provided the treatment in some sense. So there are different kinds of scenarios in this. There are a whole bunch of it. It's a separate industry and a field with billion-dollar companies because in the US, the estimated amount of fraud, I think, is about $6 billion a year. So there are companies there which just specialize in saving that amount of money, by creating technology and software in that space. But just going back to UHI and the idea of interoperable teleconsultations. I think you guys got the idea of how UHI is doing that, but UHI is a protocol for any digital health service, teleconsultation being one digital health service. I'm going to ask you a different one because one of the new open source projects that we are planning to put out in C4GT is actually in this sector in UHI, which is ambulance booking. How many of you think that you're able to get access to the nearest ambulance when you urgently need it today? Is it possible in India today to get access to the nearest ambulance that is free?
No, sir.
So, I mean, think about what is Ola and Uber doing today. Aren't they giving access to the nearest taxi that is free? So what is the leap that we need to do really to make it happen for ambulances? Given that India is a mix of private and public ambulances, right? So one of the things that we are trying to, and how familiar or how many of you have seen what ONDC has done with an app called Nammayatri in Karnataka or Kochi Mobility? Have you seen the mobility apps in ONDC? Yeah. So UHI is also a protocol that was built on the same beacon protocol. And one of the use cases that we are looking to actually implement in UHI, and the idea here is that we want to create an app for ambulance drivers where they can sign up. And also we want to be specialized in the sense we want to talk about the capabilities of the ambulance, because in an ambulance, you can actually have, there's a certain level of driver training. There's also a certain level of, if there's a paramedic on board, and if there is emergency equipment, including ventilators or certain oxygen and other things on board, and whether the person has been trained to use it. So there are different kinds of problems in that sector. And it's not easy for Ola and Uber to do it because it's not as large a market. But so we want to create a whole provider site in an open source for that. And then we want to enable a bunch of apps, including Ola and Uber, and maybe even specific or specialized apps from which you can find the nearest ambulance. As this is one of the key use cases that UHI also is looking to solve, where there could be a lot of interesting contributions from the community. So those are the three big public goods that we are going after in healthcare. So I hope that gives you guys a picture about how it works. I'm going to just use a little bit of tech, not too much, to try to help you understand how this works. So as with all digital public goods, there are certain components that the government runs, and then there is a bunch of things that the ecosystem does about it. In the case of ABDM, and I'm specifically talking primarily now about only one use case. So of the three use cases that we had, so I want to just show you the current stage. So what is live in production in the bottom is your personal health records. The other two are still in design stages. And then the health claims is just coming out into production. As we saw in the announcements, it's until now it's in sandbox, which means people can integrate and test with it, but it's not live in production. And UHI is also in the sandbox and just about to go live. Another 2 months, it'll also be live. Now, just for you to understand what's already live, these digital, the ones in the middle that you see are the digital public goods that the government is running. So you can see the HIECM, but apart from the HIECM, now you see three more boxes, one called ABHA, one called the Health Professional Registry, and the last one called the Health Facility Registry. The key intent here is that you don't want somebody who is not a known entity to be able to add a health record. So I don't want anybody to just be able to add a health record into my longitudinal health record. It has to be somebody we trust to be a real medical practitioner with a real medical facility, right? Similarly, the way you digitally identify yourself with your identity in this ecosystem is through something we call ABHA. Now, remember, the design is for people who have mobile smartphones and people who may not even have a phone. So if you don't even have a phone, the way it works in this system is you get a printed card, or you have to get yourself a printed card. But if you have a phone, you can use something called a PHR app. So there are 5 companies which have made PHR apps. These include Eka. Some people can look it up. It's called Eka.care, Briefcase, Paytm. Arogya Setu is now a PHR app. So all of you can use your Arogya Setu app, and there's an ABHA tab from which you can do all the PHR functions. Now, how does this whole idea work? Now, you are first supposed to, if you want to collect records digitally, you must get yourself an ABHA. That is assumption number 1. Two, when you go to a healthcare provider, and in many places now across India, you can go to a public hospital, you will see a little QR code pasted in the hospital. You simply go scan that, instantly you will be registered with the hospital. So you don't have to stand in a queue, tell the person, this is my name, they'll make a spelling mistake, this is my mobile number, nothing. Scan exactly like UPI, instant registration on the other side. Now, as we spoke earlier, all of these health facilities use some piece of software. So one of the things we are expecting is the person who makes the software has to make a little bit of modifications to integrate their software with the digital public goods. And once they integrate with it, they certify that their integration is good and they become an ABDM compliant software. So moment you register in a software, if that software is ABDM compliant and that software generates a new health record, it puts a link. It simply tells the digital public good that for Supreet's Abha, I have a new health record. Now, this design is very important. It does not tell anything about what is the health information. So the public good does not have any insight into Supreet's data. It simply knows that some parts of Supreet's record is sitting in hospital A or lab B or point C. And Supreet immediately will get a notification on the PHR app saying, hey, there is now a new health record linked with your address. Would you like to look at it? And Supreet can actually use this PHR app to pull a copy of the record and view it on his mobile device. So that's really how this whole thing works. There are APIs, there are all of these things available for this, including documentation. I'm going to just show you where it is available. It's available on something called sandbox.abdm.gov.in. So if any of you want to deep dive into this, you can go into it and you can go into documentation, and it has all kinds of information. In fact, we are working on a new documentation, and this has everything, including, for example, this has everything, including the swaggers and the swagger documentation that's available. So that's how the kind of the government is providing all of the APIs and the information for people to be able to integrate with these. Now, to close this out, let me just move forward. This is the journey. So like I said, this did not happen overnight, guys. It's taken a long journey to get here, starting from July 2018, which is when the first idea was published as a document by Niti Aayog called the National Health Stack, to now it going live with all specifications and everything else for integrators to integrate and join this particular program. So let's go back to this original thing. We have 200,000 health facilities in India. We have more than 2,000 people who make software for it. So what is the big challenge for the government? The big challenge is, how do you get all of these guys to come in, integrate with the ABDM digital public goods, make their solution compliant. So far, we have managed to get about 100 of them to do it. So that's the point we are in the journey. So imagine, can anybody imagine UPI? And if banks said that, hey, we will not participate in UPI. And in fact, that happened. There were several banks which said, we don't want to participate in UPI. Now, what did the government do? The government, at least there's only 35 to 40 banks that we had to deal with, and they're all regulated entities, regulated through RBI. So RBI could mandate and push them and say, no, you must do this because this is important for the country. Unfortunately, in healthcare, there is no such equivalent entity. There is no national level regulator who can push every healthcare facility and say, you must do this and you must do this by a certain time. So we have a lot of challenges when it comes to how do you drive what we call as adoption of ABDM, and therefore the ABDM journey is likely to be a little more slower than probably the UPI journey, and it's also a lot more challenging than the UPI journey, simply because of the number of entities involved and also the complexity of the type of transactions. UPI largely is one single transaction. Here we have many types of transactions and also many type of health information that we are working on. But you can already see in the bottom, a lot of people are starting to become ABDM compliant, some very big brand names you can recognize. And as they start going live, all of you will start experiencing this ABDM initiative over time. So that brings me to the end of my talk in terms of how ABDM is working. As you can see, there's lots and lots of opportunities here for ecosystem participants to come in to build innovative apps, whether it's on UHI, whether it's on HCX, or whether it's even on HICM. So happy to open the floor to anybody who has any questions. Thank you.
Thanks so much, Kiran. That was a great session, very insightful. In fact, I was glued to the screen because, while I've heard this in multiple, forums and read about it, I think the way you sort of condensed it and shared it was very, very useful. In fact, just wanted to, as we start, ask you two questions. One was, while you're doing this, right, like for all of these hospitals, clinics, for diagnostic centers, you definitely, they would be seeing value in it for themselves because, for example, registration in hospital, there is an entire, there is somebody who's sitting there who's filling up forms, supporting, and somebody else who's supporting, the person who has to fill up the form. There is all of this ROI, which is basically for the hospital, which is very clear. So do you see that ROI understanding not going through with the hospitals, or do you think it's mostly what is the key reason why a lot of them refuse? Is it more because they have to change their systems, or they are unclear about how will they get them, bandwidth or skills to do that? It would be great to just get your perspective on that practical sort of.
There are a good question there, Supreet, and there are several things that we have identified as barriers for adoption. One is actually a certain level of fear in the doctor community about digital. Just me being digital and more transparent will mean that I could get more income tax scrutiny. So today, the reality across India is that significant portion of a doctor's transaction is cash.
Correct.
And what he declares as income and what is real income could be different. And they believe that transparency, because if somebody is able to say, okay, if the government is able to say how many digital records they created, and they can then say, estimate that, hey, the amount of income tax you're filing is incorrect. So that's a fear. That's one fear. The second fear is actually very interesting. As e-commerce in healthcare is coming, and many of you might have seen the ads for e-pharmacy, for teleconsultations on TV, there is a second fear that players in the PHR side could be using the data to steal my patient. So what is stopping a Paytm or somebody else who gets access to my digital records to sell a follow-up lab test at a discount and take away my patient to a different doctor or a different lab? So those are the kinds of fears. And so how exactly can the government tackle or take that forward is going to be actually super important in terms of the doctor side of the mentality of adoption itself, right? That said, I just want to show you guys, how this program is doing. All of you can actually look at this on a site called dashboard.abdm.gov.in. Hang on, let me just paste that onto your chat so that you guys can open it and play it with it too. So here is a little thing called scan and share on the dashboard. I want to just show you that. And you can see that it has tokens issued today on the top right corner. That means 53,000 people went to a hospital and did a scan and shared a registration today. So this is starting to pick up. I don't have numbers in millions and billions like UPI, but this is the indicator of a trend. And I can tell you that in 1 month ago, when I opened it, this number used to be less than 20,000. Right? So it is starting to pick up because people are starting to see value. And especially people are seeing value wherever there is long queues, and that's mostly in government hospitals. So you'll see a bulk of the payers are all placed. You'll see that AIIMS is one of the biggest things on the, if you see your scan and share top performers, it will say All India Institute of Medicine, because they have the biggest queues. And people don't want to stand in the queues, and they can actually cut the queue by using technology. And so this is an interesting site where all of you can play with to see how the scheme is progressing. But I'm a big believer that there is going to be a very solid footing, and all of us will experience ABDM over the next 2 years as India starts to adopt?
Well, no, that was very, very, I mean, I don't think we think about these practical realities. I think there is one is the engineering challenge. The other is the practical, implementation challenge, which I think like in ABDM's case, I mean, I'm sure there's a lot of learning that you all have had, and there are very difficult challenges to overcome. And these obviously don't happen just with the policy change. This requires a lot of user buy-in. So
I do want to talk about the two key projects that we have put up in ABDM as part of C4GT, Supreet.
Sure.
So the very first project is something called Loin codes. Now, we talked about how most of the records that are health records that are digitized in India are already or from lab reports, right? Now, I have a question for you. Let's say I just wanted to plot a graph which shows how my blood glucose level is doing over time for a patient, right? Don't I need to have some way to say that this is the blood glucose, right? The information has to be the same across people wherever the information is coming from, right? For us to be able to tabulate it. Now, there is an international standard to do that. That's called LOINC, LOINC. Every lab report or every type of test has a unique code as part of that standard. India currently does not use that code. Now, I had a friend who runs a company where he goes to different labs and he collects the data from what tests they're doing and then prepares certain reports for business intelligence purposes, which he disseminates and all of that. He was telling me that for a single test like cholesterol, the names that are used by different labs, he found 52 variations. That is simply because we just don't codify or put saying what is the standard code for a test. So the first open source project that we have taken up, we have, it's being done by one of the our candidates here, Vansh, who's the candidate who was picked for that particular program, is to come up with a tool which labs can use to quickly map their tests to the standard Loin code. I mean, that sounds, by the way, the problem statement sounds easier than it actually is to do it. And, once is getting into the details of what it actually makes to do it, it's not as simple as a name matching. It's not simple as a name matching for a simple reason that the names that are used in the standard and the names our doctors use in India are actually slightly different. And so there are multiple combinations. And so the complexity is high. So people interested in that can look at that issue again and the problem that Vansh is going to kind of solve, right? Now, the second problem is this. We came up with a whole bunch of APIs in the digital public good called HICM. And we told these, we've been talking to as many people who make software for hospitals and labs and says, please come and integrate. When we started that process, we found that many of them started with a lot of enthusiasm, then dropped. And when we went and talked to them saying they dropped, they said, this is too complex, this is too tough. My developer teams are not able to fully figure out how to make this happen. And one of the big challenges was our design used something called an asynchronous design. All right. So we have many things in the design, but one of the core problems is that it has an async design in the sense that every API call you do, you simply get back a okay, and then sometime later you will get a response back as a push to your thing saying, okay, here's the response to whatever you asked me for. And that's one part. Second, there's a lot of work that has to be done in a layer called another standard called FHIR, which stands for Fast Health Interoperability Resources. India, again, does not use, just like it does not use LOINC, it does not have depth or people with expertise to use something called FHIR. So these two have become actually key barriers for implementation. So the second project that, in fact, one of our key contributors from Google is leading is how do you simplify? Can we come up with another layer of SDK that provides another layer of abstraction and makes it even more easier for people to integrate? Because if we can't get those 2,000 companies I spoke about on board as fast as we can, it will constantly, the time we will get success through ABDM is going to take longer and longer. So the second open source contribution we're trying to do is to provide an SDK to these LMIS, HMIS players that can make their integration even simpler, even faster than we are able to do today.
Got it. Thanks, Kiran. In fact, we've got Manishka who has a question. Manishka, do you want to share your question? Yeah.
So, sir, actually, I had a question. If our data is public to any portal or anywhere, if there are some patients who don't want to share their data publicly, like they don't want whatever their disease have to be shown in public. So, what about that privacy concerns?
Yeah, very good question, Ma. In fact, healthcare is a very interesting space because there is a lot of what we can call as sensitive and confidential data, right? So, for example, definitely people would not want to talk about any sexual health diseases. People do not want to talk about abortions. People do not want to talk about HIV or other scenarios. So there's a huge, even mental health diseases have certain level of taboo. And so one of the things in the design, and that's one of the reasons why I told you that the way we designed it is, first is we don't want the government to know what is the health conditions an individual has. They should know only if you provide the consent. Second, the design of the system is to put everything in your control. That is, as you as a user, you can decide whether you want that link to your Aadhaar or not. Even after it's linked, you can delete it. When you share, you can decide whether you want to share it or not. So we have put significant user controls in your side. Okay. Third, any data that we are talking about reporting for public health purposes is what we call as aggregated and anonymized data sets only. So what does that mean? So we can tell. So I'll give you an example. We'll take an example like, say, a stent surgery. We do want to know how many stent surgeries are happening, say, in the national capital region. But we do not want to know how many stent surgeries happened in Max, because that is competitive information. And Max will not want that. So it is not just about privacy for the citizen. It is also privacy for the provider that is important in the privacy preserving nature of this. So in the aggregated data set, so I'll give you an example of, say, cochlear implants. Cochlear implants are a rare kind of a procedure that's performed in a certain age group, usually below age of 10, and it's not done by everywhere. So if I were to say that one cochlear implant or 5 cochlear implants are happening in district X, and in district X, there is only one hospital capable of that, everybody will be able to come back and say, hey, I know that 5 happened in that hospital, right? So privacy preserving means that if such a scenario is there, you will never report data at the district level, you'll only report data at the state level for cochlear implants. I hope you understand the concept in what's called as privacy preserving nature of how data and data can be integrated. And those are the kind of principles that we have put into it in terms of the thinking there. Shivam, could you come online and just ask your question? I'm seeing it on chat.
Yeah, hello.
HCX is not an SDK. HCX is a digital public good. Yeah, go ahead, Shivam.
Yeah, so I'm a contributor in HCX Python SDK. So I wanted to ask, it's using FHIR inside it? I was
For the packet, yeah. So there are two parts to the HCX. One is a set of APIs. So just for it to a very high level, let's understand what is HCX doing, right? So what HCX does is, firstly, there is a standard for how do you create a health claim as an electronic e-claim document. That standard uses FHIR. So it uses FHIR, but only to prescribe how should your e-claim document be structured.
okay.
HCX gives you an open API where you can submit the e-claim document and get back a transaction ID. And then you can track the claim all the way from pre-auth till you get your money. So HCX is actually two things. One is a set of APIs that you use to essentially submit your claim and track your claim. And second is a set of data standards about how do you specify a certain e-claim document or a payment response or a query that are part of an insurance claim process. I hope that's clear. And that second part of the standard is what uses FHIR. So for you to understand this a little better, I'm going to put a link that you can read so that you give you a sense of FHIR also has two parts. And so what we use in both ABDM as well as in HCX is from these resources that we call as the FHIR resource list. So in that you can see Even what we use in ABDM is also a subset of these that we use to essentially exchange information in an interoperable format.
Okay, thank you so much. That's clear.
So Kiran, wanted to also ask you, maybe you can share some perspective. What we've noticed is that in ABDM, there is also a community, a building, some of the building blocks around this. And this is also something that you observed in different digital public goods earlier. So just wanted to ask you, how does this get orchestrated? Because everybody who's here fundamentally can also be part of that journey going forward. Like C4GT is one opportunity, but like, what's the potential of that contribution? One is, of course, the kind of projects you put right now, but just if you can shed some light on how that journey's been and like what can be the potential of this for everybody who's here.
Yeah, so I'm going to just share my screen again because it's a good question, also a very difficult question. I don't know how many of you will be able to get it, but let's think of sometimes a better way to think about this is what we call as the playground is a good example, right? So let's say we take any sport, so every sport requires first a space to play, and let's call that the playground. And then you need players to play. Each player has a role, if it's football, maybe there's a center forward, there's a goalie, there's something else. And then there are rules about how do you play, what does it mean when you win, right? Similarly, you can think of any digital public ecosystem also having like a playground. So where there are actors have certain roles to play, there are referees, there are rules, and different entities have to do these things. So I'm just going to share my screen so that we can see a snapshot of this. So that and this is, by the way, an evolving question that's happening in India. Can everybody see the screen? Let me just make it larger.
Yep.
So I've taken Aadhaar UPI account aggregator as some examples of who does what. But let's start at the very bottom. At the very bottom, you see there's something called technical specifications. So one of the things that we are trying to see open source contribution is actually in that layer called technical specifications. So Beacon is an example where Beacon and even HIECM's technical specifications were all actually done in an open source community. So what should be, or even HCX was completely designed. The specifications happened in an open source community, but it didn't start there. If you look at NPCI or UIDI in Aadhaar or UPI, those were also done by government bodies with support of certain consultants. But now that is moving to the open source community. Now, once you have a spec, you need certain reference implementations. And then you need a sandbox where somebody else can build something, test something against that protocol. And so those initially, if you see, were all done by government entities. They're starting to move to private participants starting to do that. Now, let us say I want to say somebody has built a software and they have to certify it as ABDM compliant. Who does the certification? Who does the certificate issue? So again, you need actors who can say they can do that. But generally, when it comes to production instances, if you look at UPI, the only production instance of UPI is run by NPCI. And I don't know how many of you know, but RBI asked for, it's a big thing for a country, right? Imagine if that one instance of UPI fails. It's a massive disaster for the country. So you need to de-risk it, and you need to de-risk it even at an architecture level. In fact, RBI has asked for, can we have other players also run UPI switches and not just NPCI, right? So very similarly today for Aadhaar, only UIDI runs the production instances, right? Then you have what we call as the rules, the network and the market rules. Who can connect to the UPI switch? How much will you be charged if you do a transaction? Who can connect and make an app on ONDC? So those are the market and rules. And then who is the player who makes the rules comes? So usually when it comes to the rules and the instances, production instances, the government is always involved when it becomes a digital public good. Okay. And finally, you have applications where we are always asking for market participation, which is where the private ecosystem can come in. So private players and open source players can play at the application layer, but private open source guys really play a strong role in the tech specification sandbox layers as much. But when it comes to production instances and market rules, it is mostly going to be with the government. I hope this picture gives you an idea of how digital public goods as a overall picture will kind of evolve and what roles and opportunities people have to play in it.
This is a very nice, Kiran. We have not seen a cut like this earlier across different DPIs, but this is a very, very useful cut, for understanding, because we typically feel that, there is somebody who's contributing and I'm not clear on what level of that is that, entity contributing. And it also sort of showcases what's the value that they are providing at different, like Samadhi is providing a certain value at that particular layer, whereas there is a, specification layer where there are a lot of people adding value. So thank you so much for sharing that. I think we have one question. I know we are over time, Kiran, but I think maybe if you can answer that, then we can.
Go ahead, Shlok. Please turn on your video if you can, and then ask the question.
Hello, sir. Shlok this side.
Hi, Shlok.
So, sir, previously we have mentioned that the user have the access to share the details, like which type of disease we want to mention with the government department on the particular software. So, because as the mental, like the basic personal question that the user will not be shared those diseases that are taboo in this.
No.
It
So,
may be.
yeah, I got your point. So, see, I think we have to firstly we have to differentiate between what we call as personal health information versus aggregated health information. Personal health information points out and says this information is about Shlok, right? On anything which is personal information, we want to make sure that control and consent stays in Shlok's hands. But moment it becomes aggregated and anonymized, if the technology of aggregation and anonymization is privacy preserving, it means that you cannot tell if the data came from Shlok or anybody else. You only know that X number of incidents happened, but you don't know with whom it happened, neither the provider nor the consumer or the patient.
Sorry for the.
So if you got that right, which means we will know about the number of incidences of sexual health diseases or maternities or other things, or mental health diseases. We will not know who the patient is, where they took treatment, except for even a broad area, a geographic area, but not the institution. Does that make sense for you?
So, the genuine question, like if the particular user don't want to share those of the disease, like even he knows or he or she knows about the.
They can opt out unless it's a notified disease. So, give you an example. The law says that if somebody has TB, you don't have a choice. It must be notified. So it will have to follow whatever is the law of the land. The tech layer is only an enabler. You need to think about these things as a combination of tech plus legal, of what is enforceable and how it will actually play out. So I can just give you an example. In NHS in the UK, in India, we have leaned on user decides whether I want to share my health information, including with the healthcare provider or not. Right? In NHS UK, the ruling is a doctor has the right to see all your information so that they can provide the right line of treatment. So you can't hide it from the doctor. So, and that's their law, that's the accepted practice in that country. Right? So we also have to see how India's laws and India's social acceptance on these evolve. The tech layer is an enabler, and we can go from either this end or that end, actually.
Okay. Well, thank you so much, Kiran, for your time. This was really, really insightful. And we look forward to all the ABDM related progress that will happen on C4GT. And as you put out more projects for the community as well, because I believe you're also putting up projects on the community side. I think we'll share that with the group, because one or two participants have been asking, if they were also to on an ongoing basis look at ABDM, how can they understand what projects are being put out? So I think as far as the C4GT community goes, we'll have the ABDM projects on the C4GT community listing. And anything else where, Kiran, you feel that there is an opportunity for everybody here to witness anything as part of any community discussion for that's happening on the NHA front, do let us know. because this is a very exciting, evolving, and I'm sure there are so many problem statements that you'll have to work with over the next couple of years. But really exciting to see where this entire initiative is, and really excited to actually see this scale over the next few years in the country. Thank you so much, Kiran, for your time.
Thanks so much for having me on this, Supreet and the team. But best wishes to all of you. You're on an exciting 2 months. Next 2 months is going to be quite exciting, and I'm looking forward to all of you putting hard work, and I'm really looking forward to what comes out. I'm eagerly looking to see. I'm sure I'm going to be part of some of the output presentations when it comes out by the end of August, and I'm really looking forward to see all the interesting work and creativity and contributions that all of you make. So all the very best and have fun. While you're contributing, I think, when we talk about volunteering, and I just want to share this, everything that you've heard me speak about today, I have been doing as a volunteer. Nobody's paid me to do it. I have been at it for 6 years, and I look at myself as somebody who will be contributing even over the next decade. All of us do it for our personal satisfaction, right? Each of us have our own drivers as to why we are doing it. Most importantly, it's about contributing to a cause that is larger than all of us. So in many ways, this is what I call as a paid back opportunity. Don't think too much about, it's most important that you find the time, take it out, have that passion, and go out there and do that little bit of contribution. Don't think about what rewards you will get today. Think about what really all of these little bits and pieces that you're doing will do to society over the long term. And that will give you a lot of personal satisfaction. That's really what's, imagine, 6 years ago, it was 2-3 volunteers who just got together on the board and said, let's think about what are the digital public goods that a country requires. And look, 6 years later, you are actually trying to see how to bring it to life. Another 10 years later, we'll be going and telling other countries, look, India did this. That's what we are doing with UPI today. And each of you have that opportunity to kind of do it. None of the people who actually did it are some kind of superstars or special. All of them are just people who decided to take some time out and volunteer and contribute. All right. With that, all the best.